Our topic for discussion is the pharmacokinetics of flag regimen and how those pharmacokinetic parameters in chemotherapeutic agents used in flag can influence the pharmacodynamic response in AML patients. أنا رامي صلاح خضراوي, Senior Clinical Pharmacist in برج العرب University Hospital Pediatric Oncology Center and a member in the European Society of Oncology Pharmacy. بدأت مع الأوبريشن تيم تحت إشراف دكتورة نهى صلاح الدين ومدير مستشفى برج العرب الجامعي دكتور شادي فاضل. The main objective of this presentation is to illustrate the significance of chemotherapeutic scheduling and the parameters of chemotherapy used in flag regimen and how the pharmacokinetic parameters can influence the pharmacodynamic response. And as we all know, the flag regimen consists of mainly fluorophene given for 5 consecutive days, high dose of cytarabine 2 grams per meter square given for 5 days after the administration of fluorophene by 4 hours, and the granulocyte colony stimulating factors 200 microgram per meter square started per your cycle from day 0 till day 5 of the cycle. And this regimen can be co-administered with the mitoxantrone in a mitoflag regimen or idarubicin in a flag-ida regimen. First, the cytarabine pharmacokinetic parameters. And it's quite obviously well known that cytarabine is the backbone of therapy in AML, in all protocols of AML patients. It acts as an analog to the deoxycytidine and phosphorylated intracellularly to form the active molecule of cytarabine, the ARA-CTB, arabinosyl cytosine triphosphate. This reaction is mediated through the deoxycytidine kinase, which acts on the deoxycytidine to form the triphosphate form of deoxycytidine. Results in competitive inhibition of the DNA polymerase and perhaps in inhibition of the DNA synthesis and repair. Where the plasma decay curve, the T-half is for cytarabine is biphasic, with calculated 2 T-halves of first in the steep curve of elimination for cytarabine with 40 minutes, and another T-half, terminal T-half of 2 to 2.5 hours. After 5 hours of infusion for cytarabine, no more than 3% of the drug is excreted, 12 hours, 10% is excreted, 24 hours, 40% of the drug is found in the urine, and 35% in the feces. The inactive metabolite for cytarabine, the RIU, is found in the urine. It is secreted by thus, the ability to assess the concentration of intracellular ARA-CTB, the cytarabine triphosphate, correlate significantly to the treatment response. Where fluorophene is a prodrug that's converted to its active form FRA, which further phosphorylated to its FRA-ATP form. The rate-limiting step for this conversion is the formation of a monophosphate form of FRA, which catalyzed by the deoxycytidine kinase, the same enzyme used for the phosphorylation of the standard dose of fluorophene at 30 milligram per meter square when given for 30 minutes on 5 days in flag regimen results in a plasma concentration of about 3 micromole per liter. And the peak concentration is achieved after 4 hours from starting of fluorophene infusion. The FRTB reaches its peak to the 3 micromole per liter after 4 hours. The peak concentration is proportional to the dose, and protein binding is about 29%, half-life of 20 hours. Cytarabine-resistant leukemic cells, perhaps during therapy, made leukemic cells develop cytarabine resistance, and this resistance is mediated through different mechanisms. Perhaps it's obviously known that the main mechanism of this resistance is due to the inhibition, due to the reduction in the DCK levels, the deoxycytidine kinase levels, which will prevent the metabolism of cytarabine to the active form ARA-CTP, arabinosyl cytosine triphosphate. while co-administration with fluorophene or hydroxyurea with the cytarabine modulate this reaction through decreasing the DCTP pools, the deoxycytidine triphosphate pools, which result in increasing the sensitivity of cytarabine to the DCK levels and increasing the accumulation of RCTP inside the cell. The G6F pharmacokinetics filgrastim is eliminated both by two mechanisms, renally and cell-mediated. The renal elimination is non-specific and obeys the linear pharmacokinetics, and the degradation mediated by G6F receptors or neutrophil elastase is the specific degradation. Various elimination phases of G6F resulted in a very short half-life in vivo of G6F, where G6F is removed from the central compartment by the two independent processes. Perhaps G6F passed through three main compartments, the subcutaneous compartment, and the central compartment and the peripheral. It's eliminated from the subcutaneous compartment by the Michaelis-Menten equation, where it's saturable and it's nonlinear pharmacokinetics, and eliminated from the central compartment by both mechanisms. The unspecific renal elimination, with modeled by the first order pharmacokinetics, means that it's not saturable, and specific degradation mediated by the number of circulating granulocytes, which is saturable, mediated by Michaelis-Menten kinetics, and is proportional to the number of circulating granulocytes. And note that the pharmacokinetic and dynamic parameters of filgrastim exogenous resembles the endogenous G6F. Well, the effect of G6F on RC and fluorophene in flag regimen. G6F, given alone or combination before chemotherapy, result in recruitment of AML blasts to the cell cycle, perhaps making it more vulnerable to the cell cycle specific agent like RC and fluorophene. Another study demonstrated that independent of this investigation, that the G6F rendered the AML blasts more sensitive to the cytotoxic effect of RC with different mechanisms. This chemosensitization is achieved after reaching a G6F concentration of 500 units per milliliter in vitro, and thus it could be postulated that plasma levels of 500 units per milliliter or greater is sufficient in vivo for this modulation of G6F to augment or for the chemosensitization effect of the blasts. The elimination of G6F, as mentioned before, is quite low, a T-half of 1.9 hours, and it's monophasic. Pharmacokinetics of FRATB related to the G6F infusion. FRATB accumulation is linear for 2 hours. The rate diminishes until the peak is reached after 4 hours. After administration of G6F, the G6F augments this rate of FRATB accumulation, the active molecule of fluorophene, resulted in increase in the peak concentration of FRATB. The Cmax increased, perhaps the area under the curve of fluorophene increased. However, it didn't significantly alter the elimination curve of FRATB. The elimination of FRATB is linear and obeys the first order pharmacokinetics and non-saturable, and is not altered by the G6F infusion. Increased in the peak concentration of FRATB without altering in or influence in any elimination rate for FRATB resulted in increase in a median of 1.4 folds in the leukemic blasts for FRATB. The study demonstrated in those two patients, here we can note that the FRATB Cmax is increased, and the rate of elimination here remained constant. So the area under the curve obviously is increased after administration of G6F. However, the effect of G6F on RCTP was different. It didn't significantly increase the RCTP accumulation. The peak concentration of RCTP is achieved after 4 hours of RC infusion. Despite the difference in this study from in vivo and in vitro studies, ex vivo or in vitro studies revealed that the post to pre ratio after G6F administration with cytarabine result in 1.6. However, the area under the curve in vivo did not change from pre to post GSF administration. Another study demonstrated that it did not only influence the RCTP accumulation, but rather it resulted in further declining of the RCTP accumulation inside the chloroplast cells. We cannot notice this. We don't notice this in the flag regimen because the RCTP is augmented already with fludarabine, and the GCSF augments the FRATP accumulation, the fludarabine, by increasing Cmax, increasing ultimately the RCTP in the leukemic blast cells. Okay, influence of fludarabine in the pharmacokinetic parameters of cytarabine. As we mentioned, the FRTP increases the activity of deoxycytidine kinase, increasing the rate of RCTP accumulation by a rate of 2 to 3 folds. This regimen, fludarabine plus GCSF plus RCTP, resulted in increased 5 folds in the RC or the RCTP active molecule of RC. So, what is the minimal dose that could be given by fludarabine to maximum modulate the RCTP in human leukemic blast cells? A study in Texas was published in 1997 on flag regimen demonstrated that accumulation of RCTP in circulating leukemic blasts is increased by a median of two folds when fludarabine is given 4 hours prior RC. And this augmentation process is dependent on the cellular concentration of fludarabine. The study aim was to determine the lowest possible dose for fludarabine for the maximum modulation of RCTP. To demonstrate this through the flag regimen, the study administered fludarabine at a dose of 15 milligram per meter square prior RC 2 grams per meter square by 4 hours. The next day, same patients received the conventional dose of fludarabine 30 milligram per meter square. To further titrate the dose, another group of patients received 7.5 milligram per meter square day 1. Day 2 received the conventional 30 milligram per meter square. To compare, another group to further titrate received the 5 milligram per meter square on day 1 and the conventional dose at day 2. Each dose was infused 4 hours prior 2 grams of cytarabine. The study concluded the ml plus that achieved the 10 micromole intracellular FRATP, the active molecule for fludarabine, resulted in augmentation of cytarabine in a similar way that the fludarabine 30 milligram per meter square does. However, less than 10 micromole intracellular FRATP resulted in decreased RCTP accumulation. First, the 15 milligram per meter square dose. If RCTP accumulation was linear for nearly 2 hours, the rate diminished until a peak was reached 4 hours after start of infusion. The elimination of FRTP was linear, first order pharmacokinetics, and not altered by the higher doses of infusion of fludarabine as predicted. Accumulation of FRTP was dose dependent, so the peak of FRTP for 30 milligram per meter square was higher compared to the 15 milligram per meter square. To determine if this level, the higher level of FRTP, would be sufficient to augment the RCTP accumulation in the AML blasts, pharmacokinetic profiles were compared after the 2 different doses of fludarabine. Day 1, 15 milligram per meter square, and day 2, 30 milligram per meter square. Despite the difference in FRTP accumulation, FRTP was higher in the 30 milligram per meter square dose. The rate of RCTP accumulation remained the same, did not differ. We can see the linear rates of RCTP accumulation were 290 versus 230 micromole per hour after 15 and after 30 milligram per meter square. Pharmacokinetics of RCTP and RCTP were compared in these in 4 patients. The accumulation rate and the peak levels of RCTP were similar. So cellular FRTP levels that resulted from 15 milligram per meter square were sufficient to maximally modulate RCTP accumulation with non-significant p-value 0.18. There was no significant difference between the two doses. To illustrate this, here the curve at the left compares the hours after start of fluorophene infusion and the FRATP accumulation. Perhaps it's obvious that the peak concentration is increased. The rate of elimination, the rate is still the same, but the rate of the accumulation is higher, resulting in more area under the curve and higher area under the curve in the FRATP in higher doses, 30 milligram per meter square. However, at the right, there was no difference in the accumulation of RACTP in the leukemic blast cells. The table demonstrates this kinetics in the 4 patients, where despite here the 4 patients had a high, the 30 milligram per meter square dose had a higher peak concentration of FRTP accumulation, but there is no difference in the RACTP accumulation between the two schedules of the 2 doses in 4 patients. Further titrate the dose from 15 milligram per meter square, the study used the test dose of 7.5 milligram per meter square for fluorophene, and the further titration to 5 milligram per meter square. Here, the peak level of FRTP after 7.5 per meter square of fluorophene in proportion to dose achieved after 30 milligram per meter square. The 30 milligram achieved a median of 41 micromole, the 7.5 achieved in 1 patient 10 micromole, and suggesting it's a linear relationship between the fluorophene dose and the RTP, with the same conclusion after 15 milligram per meter square versus 30 milligram per meter square. The elimination of RTP was linear. The half-life of RTP elimination was similar. Thus, it means that its elimination obeys the first order pharmacokinetics and it's not concentration dependent. The RACTP accumulation was 55 micromole per hour after 7.5 milligram per meter square. However, after 30 milligram per meter square in the same patient, the rate of RACTP accumulation was 80 micromole per hour, with a 30% reduction in this rate of RACTP accumulation. While this resulted in a lower peak of RACTP accumulation, however, the nucleotide pharmacokinetics were evaluated in 2 additional patients receiving 5 milligram per meter square to further de-escalate the dose of fluorophene, and the accumulation rate and peak concentration of RACTP were similar, the p-value of 0.9, comparing 5 milligram per meter square to 7.5 milligram per meter square. There is no significant difference between the 2 doses for accumulation rate with respect to the accumulation rate and the peak concentration. However, both did not augment the RACTP sufficiently like the dose, the conventional dose 30 milligram per meter square. The lower dose of fluorophene, 15 milligram per meter square infused over 30 minutes, is sufficient, but to augment the cytoplasm intracellular levels. However, further the reduction in this dose to 5 or 7.5 milligram per meter square is insufficient. Mitoxantrone pharmacokinetics, which is used in the mitoflag regimen, half-life, short absorption half-life between 4 to 10 minutes. Major route of elimination is the bile. The mitoxantrone showed an initial rapid phase representing distribution to the blood cells with a half-life of about 5 minutes and a long-term half-life of 30 hours after this tissue sequestration, after this tissue distribution, which resembles tri-exponential elimination curves. The second distribution have a half-life of about 1 hour, representing the redistribution from blood cells into the tissues. The extent of distribution to blood cells illustrated that at the end of 1 hour infusion, the concentration of mitoxantrone in leukemic blasts was 10 times higher than those in plasma. And after 2 hours to 5 hours, the concentration was 350 times higher. Typical peak concentration after 30 to 60 minutes infusion with the conventional dose of mitoxantrone 12 milligram per meter square is about 500 milligram per milliliter. Resulted in the large volume of distribution for mitoxantrone used the tissue sequestrations of the drug, about 4 liters per meter square, with a clearance rate of about 500 milliliter per minute. Patients given mitoxantrone doses up to 80 milligram. A study demonstrated different doses of mitoxantrone from starting of 12 milligram per meter square up to 80 milligram per meter square, and concluded that the kinetics still remains linear up to this dose, high dose. Urinary excretion of mitoxantrone is very little. It's mainly eliminated through hepatic elimination, while patients with liver dysfunction, the liver dysfunction can alter the half-life of mitoxantrone to 63 hours, where in the normal patients it's about 23 hours. So it's quite obviously known that in protocols using mitoxantrone, we used to modify the dose of mitoxantrone in mild to moderate cases of hepatic impairment, while it's maybe contraindicated in severe hepatic impairment patients. Protein binding after 30-minute infusion is only 3%. There are two identified inactive metabolites, the mono and dicarboxylic acid derivatives, that result from the oxidation of hydroxyl groups of the side chains of mitoxantrone. Follow 3-compartment plasma models with the T-halves of 30 minutes and 2.4 hours and terminal half-life of 16 hours. Clearance is 60 liters per hour per meter square. The volume of distribution is quite high at 1.5 liters per meter square. And it's metabolic, and it's categorized by its metabolic for transformation to the active metabolite hydrobenizonol, and the parent, which is active as the parent drug in vitro models. Hydrobenzone, when given orally or by intravenous administration, both have the same pharmacokinetics. They are similar, except that the hydrobenizonol and to hydrobenzone ratio is increased. Perhaps it's due to the extensive first pass effect of the liver. Bioavailability of hydrobenzone is 20% to 25%, effectively 40% if you take into account the hydrobenizonol active molecule. Cytopine pharmacokinetic parameters and how this influences the pharmacodynamic clinical response. A study demonstrated in Germany in 2005 based their data upon 28 different randomized controlled studies for all patients receiving cytopine and AML with different doses and different schedule to demonstrate the schedule-dependent pharmacokinetic parameters of cytopine and how can those parameters affect the pharmacodynamic response. It is quite obviously known that the mode of application, bolus versus continuous infusion, is of substantial relevance for this phase-specific agent, and it's highly schedule-dependent. Describing the treatment as treatment strength or treatment intensification is not significantly correlated with treatment outcome. So it's not just about the dose, not that 3 grams or 3 grams of cytopine superior to 100 milligrams of cytopine. It's not about the dose. It's schedule specific. We got to go beyond this to the schedule of cytopine, the infusion rate, the area under the curve after this infusion rate. So several aspects apart from the absolute doses need to be taken into account to obtain the clinical relevance variable. There are two aspects of pharmacokinetics and pharmacodynamics. The pharmacokinetic aspects through this study illustrated through the area under the curve, the shape of this area under the curve, the plasma concentration level, the exposure time, the exposure to plus to cytopine, pharmacodynamic response, how this area under the curve or different shapes of area under the curve can affect the clinical response of cytopine towards the blast cells, whether the high plasma levels after short exposure time more significant or the low plasma levels after long exposure time. 4 variables are taken into account: the total applied dose, the dose intensity. Dose intensity is the total dose divided by treatment days, the area under the curve, and the area under the curve with the N value, the NAUC, and the concentration coefficient of cytopine. Total dose alone or dose intensity are not considered in any meaningful way to early treatment response, such as early blast clearance CR rate. The study concluded that the results based on the clinical response of CR and early blast clearance. They used the early blast clearance because a lot of randomized trials used the CR after induction, which was containing more than one cycle. Early blast clearance that appears after a single cycle. Perhaps this the total dose and the dose intensity is not correlated because it's when non-schedule dependent cytotoxicity of cytarabine is the reason for this lack of correlation. The NEOC, the area under the curve weight by the concentration coefficient, is pharmacokinetically and dynamically weighted variable, which showed a high significant linear relation between to the treatment response, where the area under the curve is equal to the concentration of plasma multiplied by the time of exposure. And the NEOC, the area under the curve weight concentration coefficient, equals to the concentration of plasma to the power n multiplied by the t, the exposure time, where the concentration coefficient n of cytarabine was calculated in this study to 0.45. By the way, the n value, the concentration coefficient, is the value that determines how significant the concentration versus time is in the equation. If n is close to 1, that means that the concentration of plasma and the time of exposure are equal significance on the to obtain the iso effect. If n was higher than 1, that means that concentration had a more relevant values to reach the same iso effect. If you increased the concentration by fold of 2, you need to further decrease the time of exposure by more than 2 folds in order to reach the same iso effect, and vice versa for the n values less than 1. So in cytarabine, in this study, n value was 0.45, concluded that it is time. It's more correlated to the time rather than the concentration of in the plasma. Where another therapeutic agents were identified, the idarubicin of 0.78 and mitoxantrone 0.72 were nearer than 1, making the same contribution of concentration in the plasma versus the time of exposure towards obtaining an iso effect. This iso effect was named the NAOC, the AOC weight n value. Median calculated n value of RSC with 0.45. 0.45 was a variation coefficient more than 3, it was very high. This concluded that they used samples, different variables samples ranging from favorable cytogenetics to unfavorable cytogenetics, good responders and poor responders. Cytarabine quickly reaches steady state after start of continuous infusion and rapidly disappears after the end of infusion with a T-half alpha of 6 to 7 minutes and the terminal half-life T-half beta of 2 to 3 hours. And they obtained the relation between the dose per infusion time versus the concentration in the plasma. There was a high significant linear relationship between those two variables with a gradient of 13.4. And perhaps the area under the curve is also high linear to the dose and not influenced by infusion time. If the area under the curve or the dose is increased of 2 milligram per meter square per hour to 2 milligram per meter square per 2 hours, it will result in the same area under the curve. So it didn't significantly change with infusion time. The study concluded these results based on 28 randomized control trials. The area under the curve, the concentration multiplied by the T, multiplied by the number of applications, the NEOC, which is the AOC weight by the concentration coefficient N. For cytarabine, N is 0.45, C to the power 0.45 multiplied by T. And conclude these numbers. Median result of doses 1 gram per 100, intensity of 100 milligram per day, AOC of 18,000 nanogram milliliter, and NEOC was 1386. With a high significant p-value for NEOC on the early blast clearance after 1 cycle, and CR of 0.04 p-value, significant correlation between the NAOC and the pharmacodynamic response. However, the AUC dose intensity and total dose did not accomplish those significant correlation with a p-value of 0.5, 0.4, and up to 0.9 in CR rates. Concluded that under these circumstances, neither total dose intensity, nor the AUC showed any meaningful relation to early blast clearance. However, the AUC weighted concentration coefficient N showed a high significant correlation to the early blast clearance with a p-value of 0.0009. The study concluded their data based on a total of 28 randomized studies of a period ranging from 1990 to 2003 on 10,000 patients, and concluded that neither total dose intensity, nor AUC showed any meaningful relation to the blast clearance. For the NAOC, there was a high significant correlation, and dose intensity evidently did not change according to the study's definition because the total dose in treatment days was not altered when applying repeated cycles of treatment in different studies. The comparison of respective variables after adjustment to actually receive cycles with CR rate again yielded no significant correlation among total doses, dose intensity and AUC, but a highly significant correlation with the NAOC less than 0.0001. This illustrated the correlation between the NAOC through these different studies. The size of the dot resembles or illustrates the sample size of the study, and correlation with this NAOC and the CR rates with a very significant correlation with statistically significant p.0001 value. To show the potential effect, the study performed a simulation to this in-oriented approach by giving a high-dose cytosine and coupled with mitoxantrone. High-dose RC was given at 3 grams per meter square over 12 hours for 3 days. The idealistic rectangular plasma concentration time curve, AUC, plasma concentration was 13,400 nanogram milliliter, and the distribution time after distribution time for 3 hours. The net resulting AUC of 3 days was 216,000. If nothing else was altered but the infusion time from 3 hours infusion of cytarabine to 6 hours infusion, the same dose and same everything, the plasma concentration drops by 50%. And suppose the concentration resulted in 50% reduction, but the time infusion up to 2-fold increase resulted in the same area under the curve. The area under the curve evidently did not change with the same value to 16,000 nanogram per milliliter. However, the NAEOC for these two schedules is calculated and is significantly different between the two doses, perhaps due to the end value of cytarabine 0.4 resulted in the substantial difference between the two schedules of 1,290 for the 3-hour schedule and 1,800 nanogram per milliliter for the 6-hour schedule, despite the same dose. Based on this simulation, the study concluded the NAEOC would be more expected to translate this into the CR rate of 13.1%. Thus, the NAEOC approach can be used to estimate the effect on early treatment response by changing in dose or scheduling. Those are references, the different studies that I used in my presentation, and hopefully it was informative. And thank you.